disease, quite a high yield topic. So we have your cystocele, which is going to be your bladder, and the bladder can kind of bulge out. Then we have the rectocele, which is going to be the rectum, of course, bulge out, and the enterocele, which is going to be your small intestine, also coming out from the same thing. We have one thing we here called procedentia. So procedentia is basically a severe form of pelvic organ prolapse, and over here in this type of organ prolapse, there is going to be herniation through the anterior and the posterior apical vaginal compartments. So basically, procedentia means everything. Now, if you get apical prolapse, right, it's going to be quite obvious. There's either a uterus coming out or a vaginal vault over here that's going to be coming out. We have four main risk factors over here that we want to cover. Just imagine any pressure on the abdomen, obesity. If you remove the main support, which is the uterus, hysterectomy, any sort of abdominal pressure, and any sort of multiparity. Because in multiparity, so much delivery, you're going to make the muscles quite weak, and that's going to be quite problematic over here. All right, let's speak about the presentation. Presentation can vary. It can present as pressure. It can present as dyspareunia, so pain during intercourse. It can present as urinary retention, urinary incontinence. So both retention and incontinence. We have constipation, fecal urgency, and sexual dysfunction. How we manage these patients? We're going to be doing weight loss over here. So we want to be doing weight loss. As we know, we want to decrease the amount of pressure on the woman, and we can do strengthen the muscles, so pelvic floor muscles. We can put a pessary that can help us, and we can do surgical repair as well. All right. We have over here patients with severe prolonged prolapse can develop vaginal cervical erosions if the cervix and the vaginal apex protrude through the introitus, rub on the clothes, and become inflamed, denuded. So that's quite self-explanatory. If your cervix or the vagina is going through the introitus, it can lead to damage, and these erosions will present as abnormal uterine bleeding, postcoital, postmenopausal. And we can see that the treatment for prolapse is pessary surgical corrections, and erosions can be treated with estrogen, vaginal estrogen. As you know, estrogen will regulate the glands, and that really help to kind of maintain that mucosa. What is the recommended treatment in an elderly patient with severe pelvic organ prolapse? Is colposcopy. Therefore, the closure of the vagina used for elderly women who are not good surgical candidates for longer sexual activity. So colposcopy can be performed without any general anesthesia. We can just close up that vagina area. All right, so I have a question which I got 2 times wrong. So a 54-year-old female, she's gravida 3/3, total abdomen hysterectomy. For the past few weeks, patient voids and has difficulty initiating urine stream and emptying completely. She has nocturia and pelvic pressure while standing. What's the diagnosis? Of course, is prolapse, and it's not urethral diverticulum. As we can see here, there's 2 main risk factors here. One, postpartum, she's 54. It's postmenopausal, 54. Second, it's going to be abdominal hysterectomy, and maybe she was even obese, who knows, and multi-party as well. Okay, here's another question here, which is from the CMS form. We can see 77-year-old female, gravida 7, para 5. So we can see this is postmenopausal. Maybe she is obese, abdominal surgery, hysterectomy, and multiparity. So we're getting a big risk factors here. And she feels like something is moving in the mass. She has the pain. What is the diagnosis? Diagnosis is going to be enterocele. It's not cystocele, because cystocele will lead to urinary retention and incomplete emptying. Rather, this is going to feel like something is moving. So we need to know each specific one as well. We have a question over here, 68-year-old female, again postmenopausal, with vaginal spotting, dark blood stains the underwear, and she has postcoital bleeding. She has constipation, BMI 30, again 2 risk factors. Erosion near the posterior fornix, valsalva mass protrudes the high middle ring. What is the diagnosis? Pelvic organ prolapse. This is going to be pelvic organ prolapse, not cervical cancer. The bleeding can be a bit misleading, but it's going to be pelvic organ prolapse. So just quickly recap, look at risk factors. Look at old women, obesity, abdominal surgery, postmenopausal. Look at symptoms. Look at retention. Look at urination. Look at constipation. Look at bleeding. Look at pressures. And know the symptoms. Enterocele maybe has some sort of constipation. Cystocele will have urinary retention, incontinence. So hopefully you guys found this useful, and hope to see you guys next time.